My name is Beth Kramer, and my SPP and my PowerPoint presentation is entitled Quality Improvement Aimed at Deconditioning Prevention and Enhanced Mobility in Older Adults. Up to 23 hours a day is spent sitting or lying in a hospital bed. This causes muscle weakness, functional and cognitive decline, and overall hospital-acquired deconditioning, also called HAD. In 2019, the United States spent $56.5 billion in healthcare expenditures on hospital-acquired deconditioning. Nurses are pivotal to facilitating patient mobility, and despite advancements to mobility programs, nurses consistently identify mobility as one of the most commonly overlooked aspects of nursing care. On the integrated spine unit at the academic facility in the Midwest where the SPP is going to take place, the current mobility practices and protocols are ill-defined. The unit lacks standardized order sets and standardized provider goals. Nursing barriers are real and numerous, including heavy patient acuity and the concern of patient falls post-anesthesia. Importantly, leadership on this spine unit has identified that they are not meeting their daily mobility goals. The team is interested and desperately wants to have an effective mobility program. Effects of restricted mobility following orthopedic surgery are numerous, and they include urinary tract infections, pneumonia, deep vein thrombosis, all of which can be fatal. There are benefits to early mobilization after surgery, and those include decreased risk of postoperative complications, improved patient outcomes, and decreased hospital stay, as well as less hospital-acquired deconditioning. Many studies do indicate that early mobilization is feasible as well as safe. This gap in practice led to an initial query for the SPP. And that query involved looking closer at what are the factors influencing nurses' reluctance to participate in nurse-led patient ambulation. This led to the clinical practice question, and the question examines how does educating nurses about mobility affect patient mobility outcomes on the integrated spine unit. The project has numerous objectives. The first one is to better comprehend and understanding the current nursing beliefs, attitudes, and knowledge regarding mobilization. Secondly, to identify and address the nursing barriers. And thirdly, to assess educational outcomes in reducing mobility barriers for the older adult on the integrated spine unit. The project outcome is focused on decreasing hospital-acquired deconditioning, as well as enhancing mobilization and improving patient outcomes. The conceptual framework used for this project is Albert Bandera's self-efficacy cognitive theory. This theory operates on the premise that an individual is more inclined to engage in action if they believe they can succeed. The Johns Hopkins evidence-based practice model provides the roadmap for this project, and there are 3 steps identified. One is to develop the practice question, second is to gather evidence, and third is to translate this into practice. The data collection will be on the nurses on the integrated spine floor, and this will be both core and agency or traveler nurses on all shifts, including weekends. The intervention that's proposed to be utilized is the Johns Hopkins Patient Mobilization Attitudes and Beliefs Survey. This is a survey that will be conducted pre and post nursing education. The survey examines the nurse's perceptions, knowledge, and barriers to early mobility, as well as examines organizational support and resources available to implement mobility. The longstanding problem of prolonged bed rest in hospitals has been extensively studied and highlights the link between prolonged immobility and hospital-acquired deconditioning. Albert Banderas and the Johns Hopkins evidence-based practice model provides actionable strategies plus a roadmap for a successful mobility SPP. Thank you.